OEC instructors. This is Will Vaughn, EMS advisor for the region. Here to talk to you about spinal motion restriction. Dave Mooney invited me to make a videotaped presentation as I'm not able to make it to the first instructor refresher. This is the discussion about the topic that I presented in the instructor trainer refresher, and I'll also present to the second OEC instructor refresher. By trade, I'm a flight nurse and paramedic, and also on the NWAC Ski Patrol. This is relatively new to the National Ski Patrol overall, but the topic of spinal motion restriction is not new, and I would add it is not controversial. So nothing I'm going to say today is something that is without basis in evidence. One of the things that's tough about medicine is that it's constantly changing, and you know, I think those of you who've been around for a while have seen changes in first aid. The bigger challenge at this point is that things in medicine are changing quickly, and there's a lot more information flowing, so it's a challenge to change our long-held views about certain topics, and definitely using backboards is one of those things. I think in particular, as OEC instructors, the most important role you have is to facilitate this change and any resistance to the change. One of the things that I find both in EMS and in the ski patrol is if people don't understand something, they tend to be resistant to it, and if they don't understand something, they tend to revert to past practice. In this case, past practice is inappropriate and possibly harmful, so it's important that we communicate all the reasons why it's so important that we adopt this change in practice. So it's kind of winning hearts and minds by going through the evidence. And so for your sake, I'd like to put this whole practice in context. One thing that's important to remember about spinal injuries is they are relatively uncommon. For all the people that we've put on backboards over the years, spinal cord injuries are very, very, very rare. They take a lot of significant trauma to accomplish. And for the most part, they're not affected by how we handle them. Unless we're grossly mishandling people, the damage tends to be done at the time of injury. So that's important to remember. So let me put this whole thing in context. If you don't mind, I'll refer to the frequently asked questions I wrote for myself, because that'll remind me all the important points that I want to bring up with you. So the first question that I ask rhetorically is, why did we ever use backboards in the first place? Well, in 1968, a surgeon named Deke Farrington developed the idea that we could splint the spine with a board. You know, we splint other fractures with a board. Well, why wouldn't we splint the spine? So he proposed it, he wrote it in a book, and only recently have we started to question whether there was any research to back that up in the first place, and there wasn't. In fact, there was never any research, nor has there ever been any research, that shows that tying someone to a backboard is helpful. It doesn't decrease the amount of neurological injury. We've always just done it because it seemed intuitively right. Why can't you splint the spine? Well, actually you can't splint the spine. You can't splint a curved spinal column with a flat board. Even if you pad it, it's not a splint. And so hence we're moving away from the term spinal immobilization because it just doesn't work like that. So let's talk about how did we start to get the inkling that it didn't help? Well, there was a study in 1998 that compared the management of spinal injuries in the United States and in Malaysia. So in the United States, as was the custom at the time, everybody was trussed up to a backboard, immobilized, if you will. And in Malaysia, there was no immobilization, and people were generally transported miles to the hospital in things like wheelbarrows. Who had the better neurological outcomes? Malaysia. People with cervical spine injuries in Malaysia actually had better long-term neurological outcomes than the people who were tied to backboards in the United States. Well, okay, so the next rhetorical question, isn't it safer just to place everyone on a backboard? Well, not really, and for many reasons. But one story that I like to tell is the story of Virginia Yates. So this is a story that I learned about from John Politis, who is a paramedic in Albany and also a national appointment for the National Ski Patrol. And when he first started talking about the backboard issue, he brought up this story from New Hampshire about a patient named Virginia Yates. So Virginia Yates injured her ankle on the shore of a lake in New Hampshire, and the local fire and EMS responded, and were kind of weighing their options for how to get her out of the predicament she was in. Could she be assisted to walk up the hill? Could she be packaged and carried up the hill where she was? And then the decision was made, well, you know what? We have a boat. Let's put her on a boat and we'll transfer her across the lake to a dock where the ambulance could be right there. Okay, great. Well, out of an abundance of caution, they considered the fact that maybe they should immobilize her spine. Couldn't hurt, right? I mean, it's never inappropriate to put somebody on a backboard. So, in case she also had a spinal injury, they put her on a backboard. They put the backboard on the boat. They started traveling by boat across the lake to the dock. They hit some wake, and Virginia Yates and the backboard rolled off the side of the boat and sunk to the bottom of the lake, and she drowned. So, it's, for me, an emblematic story, right? Does it hurt to do something unnecessary? Well, part of the problem is that it's not just performing the act, it's all of the things that happen downstream from that act that are unintended consequences of it. But let's talk about some of the specific risks of putting somebody on a backboard. The trauma surgeons believe, and have been telling us in EMS for a long time, that the use of backboards is both harmful and without benefit. For decades, as soon as we've rolled through the door with a patient on a backboard, they have taken the patient off. And the patient never goes back on a backboard in the hospital, even though they're moved onto x-ray tables and back, they're moved from emergency room stretchers to hospital beds. The folks in the hospital have never really bought into the backboard concept. When you place a patient on the backboard, it makes it difficult for them to breathe. Lying flat makes it difficult for anyone to breathe. Certainly, the larger the patient is, the more weight's on the diaphragm, the more difficult it is for them to breathe. It also creates an aspiration problem. Patients aspirate a little bit of saliva no matter what if they're on a backboard, and certainly if they vomit, there's catastrophic aspiration. When you have someone on a backboard, they lose all ability to protect their own airway, and unless you're Johnny on the spot and can tilt them to the side, they're going to aspirate if they vomit. Any patient who didn't start with back pain, once they're on a backboard for some time, will develop back pain. This makes it very difficult to make a diagnosis in the hospital and leads to a lot of unnecessary imaging in terms of x-rays and CAT scans. When you lie on a backboard, even if it's padded, the bony prominences come in contact with that hard surface and will cause skin breakdown. The less fat that somebody has, the older the patient has, the more likely it is that they'll develop bed sores effectively while being on a backboard. The procedure of attaching someone to a backboard actually causes more movement of the spine than the patient moving themselves. Thus, in the EMS context, when we go to a motor vehicle accident, if we can have the patient stand, pivot, and sit back down on a stretcher, we prefer that to taking a patient out on a backboard, because some of these physiologic studies that they've done show that there's less movement when we let the patient move themselves rather than attempt to move them. Spinal immobilization takes a while to perform. Even when you have a skilled team, it takes a certain amount of time to attach somebody to a backboard. And depending on the situation, that may be time we're borrowing from the golden hour or golden period, whatever you want to call it, where the patient needs definitive care. They may be bleeding to death internally. They may be developing a tension pneumothorax. Their intracranial pressure may be increasing. And so if we know that spinal immobilization has no benefit, we're taking time without adding any type of benefit. Okay, so when this material from the National Ski Patrol first came out, it was called spinal protection. Since we've gotten an update, and now we're going to call it spinal motion restriction, which makes our terminology consistent with the rest of the EMS world and with medicine in general. So no longer are we immobilizing someone, we are restricting movement of the spine. And again, we're doing this out of an abundance of caution. There is no evidence that shows that this benefits the patient, but again, it seems prudent that if we suspect that someone has a spinal injury, that we avoid gross movement of the spine with a cervical collar and by trying to keep everything in line as we move. So what about the backboard? I think you'll find that the presentation of this topic, both in the hybrid section of the refresher and in the PowerPoint that was shared, which I recommend you don't use, is overly detailed and confusing. Part of what's confusing is that the term spinal immobilization is still used extensively, even though we're moving away from it, and a lot of the discussion centers around a backboard. In this new paradigm, the backboard takes a back seat to the larger concept of spinal motion restriction. And there's really two pieces of this. The first piece is we're going to be more selective about who we employ spinal motion restriction for. And the second piece is it's not about the board. If we can't splint the spine with a board, then a board is just another tool that we could potentially move a patient with off the mountain. So as I mentioned, you can't splint a curved spine with a flat board. So at best it's a transportation device. So we can manage a suspected spinal injury without a board, although the board still might be the most expeditious way to move somebody off the hill, and we'll come back to that in a second. Okay, next rhetorical question. Wouldn't you say the criteria for spinal motion restriction is very complicated in the refresher workbook? And the answer is yes. But I'm going to try to break it down for you, and hopefully you can communicate this idea in a coherent way to the students at your refreshers. Basically, the bottom line is there are all sorts of times where we've put someone on a backboard in the past where it hasn't been necessary. But I think you already knew that. You know, we tend to use the term CYA sometimes in medicine, cover your ass. And that was appropriate when we were blissfully ignorant about the harm that could come from using a backboard. But now we're going to be choosy about where we employ spinal motion restriction. We're going to try to zero in on the people who actually have a high risk of spinal injury. So I would say the most useful thing in the refresher workbook is the section where it says spinal protection is not needed. So it's not needed for low energy incidents, even when there's an injury. It's not needed for just in case. It's not needed for a headache, a brief loss of consciousness, or a concussion in a patient that's now alert and oriented and has no findings. It's not needed in patients who are up and walking at the scene with a mechanism of injury without any signs or symptoms. It's not needed for penetrating injuries unless it's midline in the spine area. And it's not needed for patients who just say, my back hurts. A lot of those patients we might have chosen to utilize spinal immobilization for in the past. But with this new protocol, we really need one of two things. In order to have a suspicion of a spinal injury, there has to be a mechanism of injury that could cause an injury to the spinal cord. And again, spinal cord injuries are rare. The mechanism has to be significant energy. So a high-speed collision, falling from a ski lift or something similar to that, a high-speed motor vehicle accident with an ejection or something like that, a pedestrian struck and thrown, these sort of things are enough force to cause a spinal injury. So we only start into this protocol if there's a mechanism that's significant. And then it's not mechanism alone. Then we either have to have physical exam findings that are significant, or we have to have an unreliable patient. So what are the exam findings? Well, the most significant ones are tenderness to the midline spine, right? So you would palpate the whole length of the spine and look for midline spinal tenderness. And the other most significant one would be some type of neurological deficits. paresthesia, meaning pins and needles, or numbness, paralysis, one side or the other, arms and legs, or legs and not arms, or arms and not legs, any of those things is a significant exam finding. So you can have a mechanism of injury with your exam findings. The other possibility is you have a mechanism of injury with an unreliable patient. Well, what would make a patient unreliable? They may be unconscious, they may have altered mental status from a head injury or some medical cause, or they might be intoxicated, which makes them unreliable, or they could have what's called a distracting injury. So what's a distracting injury? Well, it's something that's so grotesque and painful that you wouldn't actually notice that you had pain in your spine or that you had some type of neurological deficit. So you would say like an open fracture or extensive burns or something that's extraordinarily painful and distracting would be a reason why we'd consider the patient to be unreliable. So mechanism of injury plus exam findings, or mechanism of injury plus unreliable patient, means that we take spinal precautions, now called spinal motion restriction. So how does this work in practice? Well, the basic idea is we're going to place a cervical collar on everyone, and we are going to move the patient by trying to keep the spine in line. Does it have to be on a backboard? No, it doesn't. Again, the overriding principle is that all our moves keep the spine in line. It is possible and likely that if we're on the hill, we may use backboard as a transportation device. If we're using the backboard to keep the spine in line while we move the patient, then the patient needs to be fully secured to the backboard, and it's all or nothing. There is a discussion in the workbook about suspicion of whether a spinal injury is in, the lumbar portion of the spine versus the cervical versus the thoracic. Nobody has x-ray vision, certainly not in the winter while it's snowing and the wind blowing. It's all or nothing. If we have suspicion of a spinal injury based on this protocol, right, we are going to take precautions for the entire spine, and we're going to move the patient as a unit. There are other options besides the backboard for how we protect the spine. You can use a scoop stretcher, you could use a Stokes litter, you could use a vacuum mattress, you could use an ambulance stretcher. In our first aid rooms, it's appropriate that we place the patient on one of those like hospital-style stretchers that we have. That's what they do in the emergency department, and that's what we've done at NWAC for a couple seasons now. The one clarification that's come out from NSP this past week is that we may not use the toboggan itself as a spinal protection device. So, standing takedown. The standing takedown in EMS has been largely taken out of practice. Definitely the states that I work in have said that they feel that it is inappropriate to use. However, it's still in our toolbox for the ski patrol because there may be a circumstance where we have to get the patient from standing to lying down on the hill. And there's no easy way to get them sitting down. If a patient walks into the first aid room, my recommendation to you is do your assessment. And if they meet the criteria for spinal motion restriction, put a collar on them and have them actually lie down on the stretcher in the first aid room with the head of the bed elevated a little bit. That's been part of our protocol at NWAC, and that's been approved by our medical direction from Atlantic Health, and we found that to be probably the most reasonable practice rather than what we've done in the past, which is to do a standing takedown in the first aid room and then lift the backboard onto the bed, which is really not appropriate. The last piece is, can we change the device that we're using for spinal motion restriction during the course of the treatment? And the answer is yeah. Certainly, if we've gotten down to the bottom and the patient's on a backboard, when EMS gets there, if we're transferring to their stretcher, we're probably going to come off the board at their direction at that time. If we're coming inside the first aid room and they're going to be either reevaluated there or we're waiting some time for EMS to arrive, it may be appropriate to take the board out, again, keeping the spine in line, and then use that stretcher in the first aid room as our means of spinal motion restriction. All of that is absolutely fine. and it's consistent with the overarching principles. So let me review, just in summary. Number one, it's not all about the board. Number two, we're still doing this out of an abundance of caution, but there's never been any evidence that protecting the spine prevents further injury to the spine. Number three, we don't take these precautions on mechanism alone anymore. It's either mechanism and exam findings, like midline spinal tenderness or neurodeficits, or mechanism of injury with an unreliable patient. And then finally, when we're taking spinal motion restriction, we put a collar on the patient, and all our movements keep the spine in line. How we do it from there, board or not, right, is largely up to you and up to your patrol's practices. So, sorry I can't be there today. I'm happy to entertain questions if they can't be answered by the IT staff that's around. And hopefully I'll see you all soon. Thanks.